Hello friends, my name is Dr. Saf, producing academic videos on critical care for advanced trainees in anesthesia, intensive care and medicine. Today we are going to talk about the cardiogenic shock, which is a sustained state of hypoperfusion due to primary cardiac failure with significant mortality even in modern ICUs. It often develops in acute myocardial infarction, most commonly, and also decompensated heart failure, myocarditis, and acute valvular or structural heart disease. It occurs in 5 to 10% of AMI cases, more often in STEMI and when right ventricular involvement is present. Non-ischemic causes of CS include fulminant myocarditis, cardiomyopathy, and takotsubo syndrome. Mortality rates remain high, historically 50 to 80%, but early revascularization, mechanical circulatory support, and protocols have improved outcome modestly. Risk factors include advanced age, severe left ventricular dysfunction, previous percutaneous intervention or CABG, chronic comorbidities like kidney disease, liver disease, diabetes, hypertension, smoking, etc. Clinically, cardiogenic shock presents with hypotension, cool skin, mental status changes, low urine output, pulmonary edema, and elevated lactate. Key diagnostic signs are narrow pulse pressure, tachycardia, reduced cardiac output or cardiac index, high filling pressures, and signs of poor perfusion. Diagnostic tests which may suggest cardiac involvement are cardiac biomarkers which may show elevated troponins. Renal and liver function tests are important to order to see the organ dysfunction and perfusion. Arterial blood gas and lactates are also important. ECG will show arrhythmia and echo is must to look at the LV, systolic and diastolic dysfunction. Management begins with stabilization, ABC, intubation and supportive ventilation may be needed. Advanced monitoring may include arterial lines, central venous catheters, or pulmonary artery catheter in selected cases. The aim of treatment is usually to improve the mean arterial pressure and perfusion using the norepinephrine as a first line to maintain MAP. Dobutamine or Merinone may be added for the low LV output. Excess vasopressor should be avoided because it causes increase in the afterload. Fluid management is cautious using dynamic assessment and diuretics, ultrafiltration for overload. Definitive therapies address underlying cause, revascularization for ischemia, immunomodulatory or antiviral therapy for viral myocarditis, valvular intervention or surgery for acute valvular disease, and finally, arrhythmia management. Mechanical circulatory support options are IABP, percutaneous VAD or Impella, VA ECMO, and combined EC-PELA strategy, durable LVAD or RVAD, and transplantation in non-reversible cases. Adjunctive treatment address organ dysfunction, infection, and symptom management. Palliative care is important for poor prognosis, and prognosis depends on etiology, time to intervention, the severity of cardiogenic shock, organ trajectory, whether organ is improving, recovering, and related complications like bleeding and critical illness, polyneuropathy, etc. So that's all for today. I hope this video must interest you. More video like this, please subscribe to my channel.